issues. I'm really grateful for this panel that we put together. Last year, we've been experiencing heat waves for a while, but I think last summer was a real wake-up call in new parts of the country, especially for the severity and the duration. And so seeing what we went through last summer, we felt like it was very important to do a dedicated session around vulnerable populations and heat. And so I'm now going to turn it over to our moderator, Dr. Katie Huffling. She's the Executive Director for the Alliance of Nurses for the Healthy Environment. Thank you, Katie.
Thanks so much, Lisa. And Lisa and I yesterday spoke to the medical students for a sustainable future. And one of the things that we were talking about was how important transdisciplinary work is, and that we need to be working together more effectively. And I think this panel is a really nice representation of this. We have a bunch of different specialties and backgrounds, so it's really great to be walking the walk here. My background's as a nurse midwife, so I'll be talking about pregnant people and children and the implications for clinical practice in heat. I'd like to acknowledge my co-authors. We published a paper this summer on the impact of extreme heat exposure on pregnant people and neonates, and it's been the most downloaded article in the Journal of Midwifery and Women's Health in 2023. So I think it really shows the need for more information for health professionals around extreme heat and health implications. So over the past decade, heat has been the deadliest meteorological hazard reported in the United States. As emphasized by the IPCC report that came out last year, we only have a short amount of time to make meaningful action that will help to prevent the worst of extreme heat events and forestall huge swaths throughout the world from becoming too hot most of the year to support thriving human populations. On this map, currently only the places in black fall within the high mean temperature average that can make it really challenging to thrive in those areas. But the sections that are in that kind of grayish, reddish color there are projected to have a mean average temperature of over 84.2 degrees Fahrenheit by 2070, which makes it incredibly challenging to live and thrive in those areas if we continue with the status quo. And I felt like it was important to note that this, as we are looking at our dismal maternal mortality rates in this country, that for many pregnant people, maternal mortality is an environmental justice issue. In a study by Kim et al., the authors found that Black women were 3 to 4 times more likely than white women to experience maternal mortality linked to environmental causes, such as exposure to extreme heat and lack of access to thermally safe spaces. Considering that low income and populations who have been historically marginalized often face disproportionate heat burdens, excess heat may compound existing maternal and fetal mortality disparities. Populations that are considered vulnerable to the health impacts of heat exposure include the elderly, pregnant people, infants and children, outdoor workers, heat-exposed indoor workers, low income, and communities that have been historically marginalized. The human experience of heat can vary substantially. Factors that can impact this include humidity, local urban heat island effects, access to cooling, minimum nighttime temperatures, and access to shading, all of which impact the feeling of heat and the ability of the body to regulate its temperature. During pregnancy, normal physiological changes, such as increased hormonal sensitivity and changes in circulation and blood volume, can reduce a pregnant person's ability to regulate their body temperature. This in turn increases their susceptibility to adverse health effects from heat exposure. Pregnancy increases blood volume and hydration needs, which can lead to dehydration. Dehydration intersecting with high heat exposure may contribute to preterm contractions. Heat exposures can cause elevations in maternal core body temperature and maternal pulse, which can lead to fetal heart rate tachycardia and also trigger uterine contractions. In addition, high temperatures could also cause the secretion of antidiuretic hormones and oxytocin, which can also trigger uterine activity. So it can be really challenging to be a pregnant woman in the heat. Never mind that you're really uncomfortable just from being pregnant. A number of the studies in our review identified obstetric complications associated with extreme heat exposure. Extreme heat events have been found to be associated with increased emergency room visits for hypertensive pregnancy-related complications and increased risk of preeclampsia. However, it's really unclear what times in pregnancy are most vulnerable to heat impacts. Adaptation to higher temperatures also appears to be protective. Heat events close to labor onset are associated with cardiac events during pregnancy and delivery, such as stroke and heart attacks, which account for 15% of all pregnancy-related deaths. While more research is needed, higher maximum weekly temperatures have been associated with increases in placental abruption at term. We found significant associations between heat exposure and risk of preterm birth. Pregnant people with late or no prenatal care and of lower socioeconomic status may be at greater risk. Extreme heat events in the summer or during transitional months appears to have the greatest impact on early pregnancy loss. Risk of stillbirth are also increased during extreme heat events, with Black and Hispanic women more at risk when compared to non-Hispanic white women. And there are a number of neonatal complications. Heat waves, as described as a heat index, exceeded locally or regionally defined thresholds for a heat advisory, especially those occurring in the third trimester, have been associated with perinatal fetal distress, meconium aspiration, and neonatal ventilator use. Multiple studies found an association between heat exposure and fetal growth restriction or low birth weight. This higher risk was especially pronounced when temperatures were high during the second and third trimesters and in areas with historically cooler climates. Several studies evaluated the impact of extreme heat events and high ambient heat on congenital birth defects, with congenital heart disease and congenital cataracts being the most frequently researched. Heat waves and their effects, such as hyperthermia, are environmental risk factors that may be related to congenital heart disease. Air pollution associated with extreme heat events may also contribute to congenital heart disease. And temperature extremes, both high heat and cold, appear to be associated with sudden infant death syndrome, or SIDS. As we often say when we're describing the impacts of environmental exposures on children's health, children are not little adults, and with heat, it's no exception. Children's bodies take longer to increase sweat production in response to heat. They're also more susceptible to dehydration as they have a higher percentage of their body weight that is water. Infants and young children often don't recognize when they're getting overheated or when they're getting dehydrated and they need to drink more water, or if they need to take off more layers of clothes. Their core body temperatures also increase higher and faster than adults. And children spend a lot more time outside playing, doing activities than adults do. And so that also puts them at greater risk of heat-related injury. And just as we see with many of the risk factors that are seen in adults that make them more susceptible to heat-related injury, these are also risk factors in children. These include chronic diseases such as diabetes, obesity, cystic fibrosis, medications such as anticholinergics, opioids, and stimulant medications. And especially in infants and young children, they're not able to communicate their needs or be able to move into a more protective environment. So they're really looking to adults to help reduce these heat risk factors. The most common symptom in children of heat exposure is dehydration. As the body continues to heat and is no longer able to compensate for the increased ambient temperatures, their core body temperatures rise and fever can occur. As the body temperature rises, this can lead to tachycardia, metabolic acidosis, agitation, seizures, and even cardiovascular collapse. Heat exhaustion is caused by a combination of heat and dehydration. And in children, they may experience things like tiredness, faintness, fever, and thirst. This is treated pretty easily with rest, cooling, and hydration with electrolyte-containing fluids. Heat stroke is a medical emergency and occurs when the core body temperature rises about to 104 to 105 degrees Celsius, Fahrenheit. With heat stroke, the ability to sweat is lost and they need to be taken to a healthcare facility for intensive cooling. And I thought it was especially important to highlight exertional heat stroke. It's the most common cause of death and disability in youth athletes. And I was recently at a meeting with some climate scientists, and one of them there was talking about her brother-in-law, who's a football coach, I think in Alabama or Louisiana. And she was saying he really was kind of poo-pooing the issues around heat with these young athletes, because he's like, well, it wasn't that bad when I was a kid, you know? And so I think there's just a lot of education that we need to be doing with coaches and families that have child athletes to ensure that they're playing in the safest manner possible. These are the risk factors for exertional heat stroke. It's important that coaches and parents be aware of the risk factors so that they can put policies in place to prevent that type of heat stroke from happening. It's also important that children become acclimatized to heat when playing sports, with a gradual increase of athletic activities in higher heat situations. There's also over 120,000 children in the US who work as farm laborers, and they may also be at risk for exertional heat stroke. And many of those kids are not covered under OSHA, like if they're at a family farm. So again, if you're in a farming community, being able to counsel your patients with pediatric family members around exertional heat stroke and what needs to be done. So the recommendations are that coaches and parents need to ensure that children are consuming enough fluids before, during, and after activities. Activities should be modified as needed, such as moving to the shade, decreasing length and intensity of the activity, and canceling or moving the time of the activity to a cooler time of day. Personnel involved in those activities should also be trained on how to quickly identify symptoms of heat-related illness, and that they are able to provide a proper, timely response, because that, especially with exertional heat stroke, time is really of the essence. And recommendations for pregnant patients and families. As health professionals, we need to be counseling our pregnant patients on ways to reduce the impacts of heat on pregnancy. We can also advocate for things like air conditioning and energy cost reimbursement to be covered by Medicaid and insurance for low-income pregnant people. Patients should also be counseled about what to do if they have an extreme weather event and the electricity goes out and the temperatures are high. Being prepared and proactive about cooling off can help mitigate the worst impacts of heat. These are some resources for providers, and the final resource here from the National Athletic Trainers Association is really awesome. Anyone that has kids playing sports, I'd highly recommend getting it to coaches or other personnel. If you're a pediatric provider, having something like that you could hand out to your patients, I think can do a lot to educate the public on the really significant issues that can occur with high heat situations.
Hello.
Hi, Mr. Rodriguez.
And I will turn it over to
Hi, Dr. Maria Chansky. How are you doing?
which I believe is Manny, correct? Yes. You.
All right, perfect. So nice to be with you all today. My name is Manny Berenji. I'm an occupational and environmental medicine physician. I'm based at the VA Long Beach Healthcare System in Long Beach, California. I also have faculty appointments at UC Irvine School of Medicine, as well as program in public health I do a lot of education of medical residents and hopefully medical students at UC Irvine on climate education, which I'm really excited about. But really the purpose of my talk today is to talk about the impact of heat on outdoor workers. As an occupational and environmental medicine physician, I've treated many of these individuals through the course of my career, and I just wanted to shed some light on what I've seen. So no disclosures. So let's talk about these folks. So during the course of my career as an occupational and environmental medicine physician, I've had the great fortune of taking care of these outdoor workers. Many folks that I had taken care of during my occupational and environmental medicine fellowship at UC San Francisco. I actually did a rotation in the Salinas Valley, and I took care of a lot of these folks who were working the fields day in and day out. And a lot of these individuals would come into the clinic complaining of heat-related illness. Luckily, we were able to take care of these individuals before things started to manifest, but that really informed me as a clinician, even to this day. I've also worked at Duke University, and I was faculty there for a number of years. And I took care of a lot of outdoor workers in my scope of practice, taking care of day laborers and construction workers. And that work continued when I moved up to Boston. And I actually ran a work injury clinic for a number of years at Boston University School of Medicine. And that's really where climate really started to make sense to me, because I was seeing the full brunt of how climate is impacting our outdoor workers. So let's talk about these guys. So about 33% of workers in 2022 were exposed to the outdoors as a regular part of their job. That's a pretty sizable number. And I got these statistics from the Bureau of Labor Statistics, so I highly recommend that you take a look at some of the information they have on their website, because it really can inform your practice. As I was preparing for this talk today, I really wanted to see what kind of data is available specifically around heat-related illness as it impacts workers. So if you actually go to the CDC website, there's a climate and health website that specifically has a tab looking at the number of incidents of heat-related illness among workers. And they've only collected about 10 years worth of data to date, but it was really informative to see that they're actually making an effort to track these types of illnesses, especially from the occupational health perspective. So I'm very happy to see that. So let's talk about heat hazard risks. So in my work as a clinician taking care of these folks, there's a lot of different factors at play, especially when these workers are working for a number of hours on end without any type of access to shade or cool water. But we also know that there are additional hazards at play. Those who are over 65, those who are overweight or obese, those who have a history of heart disease or hypertension, or those individuals who have mental health disorders, for instance, and are taking specific medications for that, these folks are at higher risk. And in my research for this presentation, I actually learned to really understand the effects of heat on vulnerable populations, specifically African American, as well as Hispanic Latino workers. And a lot of these folks are disproportionately affected. So I know this is a busy slide, and I just wanted to give a shout out to Dr. Schenker at UC Davis. He's done some phenomenal work, especially around the California Heat Illness Prevention Study. I'm not gonna get into the details of this for the sake of time, but really I wanna educate everyone here today to take a look at the study and see what the impacts of heat on agricultural workers in the state of California. It's pretty remarkable to see how it's actually impacting people. And a shout out to the Union for Concerned Scientists. They actually have produced some really great reporting on this topic of impact of heat on outdoor workers. This is a report that came out a few years ago, and I highly recommend that you take a look at this. Really, in all essence, they really had the ability to take in different data inputs. I'm not only looking at local data from local municipalities, but they actually were able to get US Census data and looking at specific occupations. And they actually did find that outdoor workers are disproportionately affected by heat. So let's talk about some prevention strategies. I know we don't have a lot of time, but at least we can start to broach the subject. So this is a position paper that I was a part of through the American College of Occupational and Environmental Medicine. We published this paper a few years ago, really looking at how, specifically how occupational and environmental medicine physicians and providers can take care of workers who come into our clinics, and really focusing on primary, secondary, as well as tertiary prevention. So please take a look at this paper when you can. And this is another paper that recently came out from my colleagues, Dr. Perkison, as well as Dr. McCarthy. They're both based in Texas. They actually had the opportunity to look at 9 years worth of data from a population of workers in Texas, and really looking at how heat illness prevention programs can really benefit not only workers, but employers across the state. This is just a little plug for OSHA, or the Occupational Safety and Health Administration. They actually have some really good infographics. So if anyone's interested in sharing this with their colleagues or coworkers, highly recommend that you take a look at that website. All righty, excuse me. Let's take a look at some policy solutions. The NRDC actually has come out with some really good information about how many states in the US actually have a heat standard in their state. And you can actually see them in blue, not many. California does have a heat standard, I'm happy to say that, as well as Washington, and these are primarily focused on outdoor workers. Minnesota actually has one that's focused primarily on indoor workers. Colorado has a heat standard that's focused primarily on farm workers. And Oregon has a heat standard focused on both outdoor and indoor workers. So you can see we have a lot of work to do, at least from the state level. But Biden and his administration have really been pro-worker, at least when it comes to educating not only clinicians, but really other stakeholders across the space about how we can protect our workers from extreme heat conditions. This actually was a fact sheet that came out in 2021. And really, President Biden and his administration have been at the forefront of this movement. Just additional updates from OSHA, as well as the Biden administration. This came out in 2022. Then Labor Secretary Walsh had joined the Biden administration to announce the first ever national emphasis program to protect workers. This was a really key point. But just to let everyone know, there is currently no federal heat standard in the United States. So we still have a lot of work to do in this space. And I'm not sure if you guys saw this announcement a couple of months ago, but the Federation of American Scientists had an open call for policy ideas, specifically around extreme heat. I'm actually a policy advisor for this group, so I highly recommend that you continue to tune in, because this is going to be a great way to get ideas to really try to gain more momentum in this movement. So summation, the evidence is conclusive. Extreme heat does impact outdoor workers. Only a handful of states have an actual heat standard, and there's currently no federal heat standard. Heat illness prevention programs, specifically around medical surveillance, do work, but unfortunately, they're not uniformly applied. So we actually need more data infrastructure to develop early warning systems that fully integrate with not only healthcare systems, but public health agencies, emergency response agencies, local and regional governments, as well as employers. I'm not sure if you all have seen this documentary, Too Hot to Work. Who's seen it? I wish we had time to actually do like video screenings, maybe something to think about for the future, but I highly recommend that you all take a look at this documentary. It really kind of shifted my worldview about the impact of extreme heat on workers across the globe. Thank you guys so much. Happy to take questions later.
Hi, everybody. My name is Bob Fader. I'm a psychiatrist in New Hampshire. Recently retired from seeing patients and spend most of my time now working in various climate groups, which are listed here for you. Like Dr. Maybach, I have no conflicts to report other than my involvement in these various groups. So going to talk today about the effect of heat on psychiatric patients. And psychiatric patients have one of the highest risk factors for exposure to high heat environments. And it's important for all of us as healthcare workers to be aware of this. I'm going to go through a variety of psychiatric diagnoses and describe how each one of these groups is subject to increased risk. First, starting with schizophrenia, this one particular group of patients probably has the highest risk of anybody in a heat emergency. And this was brought out quite dramatically in this study, which was just recently published, which looks at the effect of the recent heat wave in British Columbia on various people with various types of chronic illnesses. And I don't know if this came out clear enough to really read well, but this shows all the chronic illnesses that were examined in this study. And it's just about everything you can imagine. Kidney disease, ischemic stroke. Whoops. Wait a minute. I screwed up something here.
They're doing it behind the scenes.
Will they do it? Okay. Well, we can try and look at this as best we can here. Most of your chronic illnesses were looked at in this study, and this vertical line here is the average risk of mortality in this study. So everybody was averaged into this risk of 1.0. And the various chronic illnesses range on either side of this. You can see most of them are fairly quite tightly packed between about 1.5 times average risk and 0.5 times average risk. And this one outlier way out here, which is 3 times average risk, is schizophrenia. It really stands out among all these chronic illnesses, cardiovascular, pulmonary, kidney, metabolic. Schizophrenics are just at an incredibly higher risk if you look at any of these chronic illness groups.
That's for death?
This is for death, yes. Another way of looking at this is that schizophrenia affects 1% of the population, but is associated with 8% of heat-related deaths. Now, there are many reasons why schizophrenics are at such high risk, and one of these includes simply that when they are acutely ill and delusional or paranoid, they are confused or have bizarre ideas related to heat and assistance seeking. Homelessness and poverty are very high in this population, and that means that they have poor access to air conditioning and reduced access to liquids. Part of the illness of schizophrenia involves impaired hypothalamic heat regulating mechanisms. This is a physiologic problem of the illness independent of any medications that they take. But in addition, antipsychotic medication impairs heat regulating mechanisms as well. So they get hit doubly here. And in addition, a lot of schizophrenic patients are taking anticholinergic medications, and these impair their sweating, which again increases their risk of becoming overexposed with heat. There was a really wonderful and heartbreaking story about this that the Washington Post published just a couple of months ago, a story called Heat's Hidden Risk. And this is a story of Stephen Goodwin, a 32-year-old man with schizophrenia, who walked around Phoenix, Arizona in 114-degree heat for 2 days before he was discovered dead in an empty field from heat exhaustion. And this story kind of reconstructs the last 48 hours of his life in a very dramatic and insightful way, which gives you an understanding of what these patients are at risk and exposed to. Next group I'm going to talk about are patients with major depressive disorder, which is the largest group of patients that mental health providers see and probably the largest group of psychiatric patients that any health providers see, especially primary care physicians. The incidence of major depressive disorder is anywhere between 15 and 20% of the population, depending on which epidemiologic studies you look at. This is a study that was done in New York that looks at the frequency of emergency room visits as the temperature goes up. And you can see that emergency room visits stay fairly stable for patients with mood disorder until you start getting into the warmer temperatures here, and then they really start going up. So that these patients are under stress when temperature goes up, and they will report into emergency rooms. It's also been shown in a number of different studies that rising temperatures are associated with rising suicide rates. This number is remarkably consistent across studies, that suicide rates go up 1 to 2% for each 1 degree centigrade rise in ambient temperature. And if you project that if we do nothing to stop the increase in global temperatures, we're going to go up by 8.5 degrees centigrade by the end of the century, you can do the math just to see what kind of increase in suicide rates we're going to be looking at. And a significant number of people who commit suicide, of course, have major depression. So this greatly affects this group. Medications that patients with depression take also contribute to their increased mortality risk. The common antidepressants that most of these patients are on, either SSRIs or SNRIs, all increase sweating, which can lead to increased dehydration. And the older antidepressants, which you still see some people on, Elavil, amitriptyline, imipramine, they actually have the opposite effect. They reduce sweating, but that can lead to increased body temperature. Also, an increasing number of patients with major depression are now on antipsychotic medications. These medications have proven to be very effective add-on medications for patients that don't respond to antidepressants alone. And the ones that you usually see in the depression group are Vraylar, Abilify, Seroquel, Latuda, or Zyprexa. All of these medications, as I just mentioned in regard to schizophrenia, can directly impair hypothalamic heat regulation, which again puts these patients at higher risk when ambient temperatures go up. Bipolar disorder patients, also mood-related disorder. There are a number of factors that increase their risk. In a manic state, you have increased physical activity, which increases the amount of heat your body is producing, which can complicate it if you're already in a hot environment. Most bipolar patients are now on antipsychotic medication, and again, these medications impair hypothalamic temperature regulation. Lithium, which is commonly used in bipolar disorder, can increase dehydration because it causes increased urination. And dehydration in turn can cause lithium toxicity, which itself can be a fatal complication. And finally, the increased suicide risk that I mentioned as well also directly affects this population. The rate of suicide in bipolar disorder is quite high. Dementia. This is an interesting group to look at. The overall rate of morbidity and mortality for demented patients in heat episodes is actually lower than the average population. They are actually at some protection because many of them are in nursing homes or other assisted living care facilities where they're being taken care of and they're being watched out for. So the increased risk in dementia really just affects those demented patients who are living at home. And they have a number of risk factors. They have decreased awareness of heat depending on the level of their dementia. They have decreased hypothalamic regulatory ability, which again is a function of the dementia itself. As the hypothalamus, as other brain areas, just becomes less efficient with dementia and doesn't do what it's supposed to be doing as well. Demented patients can be very confused about what to do if they know they're at risk and suffering from increased heat. And again, this group is often faced with limited income, which reduces their access to air conditioning and reduces their access to adequate hydration. Attention deficit hyperactivity disorder, ADHD. Interestingly, this group is also at increased risk in heat. This is due to the fact that these patients also have increased motor activity, which results in increased heat production. And stimulant medications are not a help when you're exposed to increased heat. Like a lot of other psychiatric medications, these medicines impair hypothalamic heat regulation. They reduce the ability to sweat because they cause vasoconstriction. And they actually reduce the unpleasant sensation of overheating. You just don't feel as hot if you're taking a stimulant as you do if you're not. Substance use disorders is the second largest group of patients that mental health professionals see and primary care physicians see with psychiatric conditions. Substance use disorders affect 10 to 15% of the population, and this group is at significant risk in heat emergencies as well. Variety of reasons for this. When you're high from just about any substance, you just don't feel as hot and you're not as aware of being overheated. This is another population for which homelessness and poverty are often a problem, again, leading to poor air conditioning access and poor access to liquids. Two specific drugs of abuse, methamphetamine and ecstasy, directly interfere with hypothalamic temperature control. Alcohol increases dehydration. And an interesting and sad statistic related to this is that 18% of all heat-related deaths involve drug overdoses simultaneously. So what can we do as healthcare professionals about this? Well, fortunately, there are some things we can do. One is simply to educate each other like we're doing today and be aware of the risk that the psychiatric patient encounters in heat. I think it's very important to include this kind of training for residents in their resident curricula. And it's also very important for us to educate our patients. The Climate Psychiatry Alliance has actually come out with a very nice handout which looks like this. It's two-sided, which basically tells people, psychiatric patients and any other patients, what they can do to survive heat waves. We have these in 3 languages, English, Spanish, and Chinese, and they're available at the front of the stage. You can come up and pick one up and take one home with you. They're really very good, and they can be copied and handed out to patients. Finally, another thing that we can do is be aware of the Community Mental Wellness and Resilience Act. This was introduced into both the House and the Senate back in 2022. The House bill number and the Senate bill number are up on the screen there. This is a bill which would establish funding through the CDC for community-based programs designed to address mental health issues of the climate crisis. So I'd encourage you to become familiar with this bill. I'd encourage you to help your legislators become familiar with this bill, especially if you're going on to the Hill on Tuesday. And if Congress ever gets its act together and passes anything, this would be a great help in that direction. So I think that's it. Thank you very much.
Oh, yeah, thank you.
All right. So I'm Hayley Blackburn. I'm an associate professor of pharmacy practice with the Skaggs School of Pharmacy at the University of Montana. I'm also director of outreach and education for the Skaggs Institute for Health Innovation, which is focused on advancing the role of pharmacists to improve rural health disparities. And I'm a co-founder of RX for Climate, which is a pharmacist-led organization globally interested in climate and health issues. And today I'm going to give you the medication management perspective on preparing vulnerable populations for heat waves. So meds and heat, why do we care? A few reasons. So first of all, heat can affect medication stability. Heat can also affect medication pharmacokinetics. It can be involved in medications altering thermoregulation and increasing the risk of heat-related harms. And finally, as has already been really nicely demonstrated, medications are a cornerstone of clinical management of vulnerable populations. And so it goes hand in hand with us protecting vulnerable populations that we consider how medications are involved in their various risks. So we'll start off with heat and medication stability, partially because this feels to me when I bring up this conversation to a lot of people that this is the first thing that comes to mind. And I think this is because we include this with our standard medication education, store in a cool, dry place, that people think of this and say, oh yeah, in heat waves, I need to protect my medications, which is true, but also we know anecdotally and from evidence out there that we're not necessarily great. So there's a study that says 30% of people, when they look at home storage of medications, they do not store their medications appropriately according to manufacturer's labeling, so that roughly room temperature range. However, manufacturers are only required to report labeling as we have studied it at this temperature. This isn't a proof that it is only stable within this temperature range. So real world studies, when we go back and look at that, indicate that actually there's probably acceptable stability at much higher temperatures through temperature fluctuations. But these studies don't often examine the effects of maybe packaging changes, tablet splitting, the things that we do with humidity and other common factors, which we know are definitely human-caused sources of potential error or differences here. I won't make us raise our hands as we did before in our disclosures of who's guilty of those things, but I will. So there are definitely products of concern. Refrigerated medications like insulin, various biologics, vaccines, where we need to be worried about cold chain. Emergency medications like epinephrine and naloxone, or even delivery devices like metered dose inhalers, where heat exposure can actually either degrade the stability of the drug or change how much drug is delivered. These studies although also actually point to maybe a little bit more stability than what the manufacturer labeling does say. So while we do need to pay attention to this, insulin has been shown to be stable at higher temperatures when we study it in more extreme conditions, that it can be left out at room temperature even when those room temperatures are higher in the 100-degree range. Epinephrine, naloxone, yes, they are stable at slightly higher ranges. You don't want to cook them in a car, but they are probably okay for short periods of time being at high heat. So we want to be aware of that, but maybe it's not such a big issue. Something that is medication, very medication adjacent that I did want to point out is point of care glucose testing can actually be really significantly impacted by exposure to heat. So there's studies out there that show meters and test strips can, even in just short-term exposure to heat and humidity, just 15 minutes in this one study resulted in erroneous results of up to 33 milligrams per deciliter above control values. So very much clinically significant when we look at this and we think about people who are relying on these numbers to manage their insulin. When we get into heat effects on medication kinetics, there are a couple of different mechanisms here. So there's direct mechanisms where increased vasodilation of the skin and peripheral perfusion may alter the way that we absorb drugs transdermally, topically, or even through subcutaneous administration. That may change the way that the drugs are distributed. And then there are indirect mechanisms, like we mentioned earlier. Dehydration can lead to alterations in drug distribution and elimination, where we might see toxicity as a result of dehydration, increased serum levels, and potentially decreased renal clearance. So a lot of studies here with this have been really more maybe in like lab-controlled settings, small populations, or have even been just kind of theoretical mechanistic things. And we have not necessarily had a lot of good context in terms of how this plays out in real world. However, there was a study that was just very recently published looking at ambient temperature and insulin use and risk associated with hypoglycemic events during heat waves. And what they found when they looked across US and Taiwan populations, they found that insulin users were at a 40% higher risk of serious hypoglycemic events on days with heat index greater than 99th percentile versus days with a heat index in the more normal range. So the proposed mechanism here being that cutaneous vasodilation that ultimately results in increased insulin absorption and a risk of hypoglycemia. So we're seeing this play out and maybe points to us thinking about having heat-related recommendations, heat day preparedness in the same way we think about sick day preparedness for people with diabetes. So this is just a slide here to reinforce, discuss the different mechanisms by which medications can alter thermoregulatory capacity or otherwise change risks. And so they can alter the way that we have our central thermoregulation mechanisms working. They can impair sweating, they can impair vasodilation, they can reduce cardiac output. They can change the way that we engage in behavioral thermoregulation by having heat avoidance behaviors. So all of these different classes of medication may ultimately impair. And then we also have medications that may exacerbate underlying dehydration or electrolyte or abnormalities as well, so leading to downstream consequences of maybe some mild dehydration then being worsened by medication use. I will spare you the pharmacology lecture to go into all of these in-depth details, partially because it's already been covered, and also for the sake of time, but just a couple of things to note here. One, these medications, you can see a lot of them impact heat regulation through multiple mechanisms. And two, these are really, really commonly prescribed medications too. So these are things that we see on nearly every single med list when we're dealing with patients with chronic conditions. So we know that medications are just one more layer in the calculation of ultimate heat-related risks for patients. And this has already been mentioned. There are vulnerable populations. This goes hand in hand with medication use. And so we'll see people as they age, they have, as a function of age-related decline in thermoregulatory capacity, now they have more and more medications that may ultimately further decrease their thermoregulatory capacity, or we may see overlap between people with diabetes who have autonomic dysfunction, who have reduced thermoregulation, who ultimately also have to deal with insulin and have to manage their glucometer and everything. So many, many layers. Medications are just one of those that we need to be aware of. So what do the data say for us about which medications and what should we do? So we know broadly there are these classes of medications and they do increase risk. However, most of the current evidence that we have, a lot of what we have just in theory, mechanistically, we know that these drugs should increase risk based on the way that we know the pharmacology works. However, we do have observational studies as well that say there are these broad classes of medications that increase risk of dehydration, of hospital admission for heat-related illness. And consistently, we see studies that say things like anticoagulants, NSAIDs, antipsychotics when they're new start, especially in co-prescribing with ACE inhibitors and diuretics. Those are high risk. One study suggested up to a 3-fold increase in hospitalization with initiation of these drugs during heat events. Increased risk of heat-related hospitalizations in older adults taking heat sensitizing medications throughout the summer months. Interestingly, here, they did not see a synergistic effect with heat waves. Use of levothyroxine being pulled out of one study as something particular to older adults and risk of hyperthermia. So thinking that we may be using too much levothyroxine in older adults that ultimately increases their risk. And short-term associations at relatively low temperatures where we start seeing increased risk of visits for substance use or overdose in hotter temperatures. We do have just a few studies that say, here's maybe what can be protective. So statins and empiric potassium in people with higher doses of furosemide may actually be helpful, but these are really, really limited. Mostly we have general statements about what might be harmful and not so much about what might be helpful. And so we have relatively few well-controlled studies that really look at this. Overall, when we think about the magnitude of potential impacts of medications, the proportion of studies that are available are fairly limited. Most studies look at entire medication classes rather than individual, like within a class, so we don't really have good guidance of choose this medication over this if we do require an ACE inhibitor for this patient or the like. Most studies don't evaluate medication doses or things like anticholinergic burden, where we know that it's not just one medication, it may be compounding effects, or it doesn't look at drug-drug interactions. And most studies evaluate specifically heat-related illness, but not other outcomes like falls or cardiovascular events or things like that during heat events and how medications might play into that. It's always difficult to associate risk of medication with the risk of the underlying comorbidity, and there's just generally a lack of evidence to really finely tune our clinical decision-making. So what we're left with a lot of this is knowing that these risks exist, we have to kind of use our best clinical judgment and lean on a lot of our pre-existing medication management principles. So one, considering medication management as a part of our careful risk-benefit analysis in any type of prescribing decisions that we make, and as part of any heat action plans that we might make for both individuals and at a population level. We should be using the lowest effective dose for the shortest possible duration, and we should probably avoid, if possible, adding new medications during heat events, and thinking about also the additive effects of medications across classes as well. So thinking about those drug-drug interactions preemptively. And we should also have a proactive, individualized plan to avoid dehydration and manage fluid status, especially in those taking diuretics or in medications that might decrease thirst. So for instance, ACE inhibitors, where we know that there are going to be maybe greater risks of dehydration, so being proactive there. At a systems level, we can think about all of these different things, including medication review, which we should be doing regularly anyway, but really with an eye toward high-risk medications, drug-drug interactions, and high-risk conditions and how those overlap. Thinking about how we can integrate this into pre-existing structures, medication review processes that exist, and reimbursement structures that go along with them so that there are incentives for us to engage in this education and these reviews. So things like our comprehensive medication reviews, 30-day medication reviews that are required by Long-Term Care Institute or Medicare annual wellness visits, things like that. How do we integrate this into our potentially our pharmacy systems when we're dispensing, or an electronic health record where we can have risk alerts for high-risk medications, potentially when they're co-prescribed with underlying conditions, taking a population health approach in terms of screening for risk factors, individualizing heat response plans with medications in mind, thinking about that, thinking about how medications and medical supply storage could impact patients' care. And thinking also about pharmacists as a really key part of your team when you're planning either within a clinic, a health system, or at a public health level to try to address heat-related risks. So I'll wrap up here with a Montana case study. So Montana is challenging for a lot of reasons in providing healthcare, rurality, access to healthcare. We also have a particularly high population of older adults. And if you look here on the map on the left, older adults living alone. And then on the right-hand side, we have a map of the number of days over 90 degrees in summer 2021, which is particularly high for Montana. 90 degrees is hot for us. This also coincided with a really bad wildfire smoke year. So this is one of those times where people are left with the decision of, in low prevalence of air conditioning, whether they're going to cool their homes at night and open up to the wildfire smoke, or whether they are going to keep their homes sealed and maybe have some clean-ish air inside. So a lot of challenges in thinking about how to navigate these problems from a heat risk perspective. So despite Montana being almost entirely a health profession shortage area, we do have pharmacists and pharmacies located all around the state with close partnerships with the School of Pharmacy. And so we're working right now on a program that we have a telehealth-based medication review and chronic disease stage management program that does outreach to patients across the state, provides education, provides medication reviews, and partners with local pharmacies that already have that trust and rapport within their communities. And what we're doing is working in just targeted medication reviews for medications that might increase heat-related illness. We have a bunch of diabetes patients that are enrolled in this program, and we're looking at how we counsel better on use of glucometer, storage of insulin, how to make sure that you're managing your diabetes well during the heat. So thinking more about how we integrate this into systems that we already have and taking advantage of the data we have, the relationships that we have, and being kind of forward thinking in these models. From a policy and systems change level, I think that a few things that we could look to, one is proactive testing requirements for medication stability for pharmaceutical companies as they're producing this. So right now, like I said, this is not actually required. It could be something that we require pharmaceutical companies to actually do, so we have those data available to us and we're not just guessing. Push and pull incentives within existing opportunities for medication review, and what I mean by that is some we should just be requiring this as part of the components that we need for a medication review. Right now, in theory, we should be doing that, but be more explicit about it. And then pull incentives being, hey, how do we actually reimburse for this education or these specific reviews? We need more funding and research to better develop clinical guidance for medication management during heat events. And finally, we need health professions education. So both accreditation standards and thinking about how we integrate learners into our heat planning so that they are introduced from like an experiential perspective early on in their education. That is all that I have.
Hi, everyone. I think I'm next up. I'm Gaurab Basu, and pleasure to join you all in this conference and to follow these great presentations. Just wait for the slides to get uploaded.
Great. Okay, Rob, go ahead.
Okay, hopefully you'll let me know if you can't hear me or anything, but it's really nice to be with you all here today. And I'll put a little bit of a spotlight on heat and the health of the elderly. And in some ways, it's good that I'm going last here because so many of the themes that have been touched upon through those great presentations are obviously very relevant to this population. So I'll go to the next slide. So I'll just spend a slide or two here just to give some overall points about just how extraordinary the heat has been. I know I don't have to tell this audience that, but the numbers really were mind-boggling last year in understanding how much heat was absorbed within our atmosphere and its relevance to heat waves in our patient population. 2024 is starting even higher in January than those 2023 numbers. Next slide. And of course, I'll just read, just back for a second. Back a slide. Yeah. We'll just highlight again just how critical stopping the use of fossil fuels are in getting us to where we need to be. So let's go a little into some of the mechanisms. Next slide. I'm gonna speak a little broadly about just kind of the overall mechanisms because it's important to just understand that, to understand what makes some of these challenges more difficult for the elderly population. So next slide. Next slide. So many of you are familiar with this great piece in New England Journal, but the heart of the compensation that our bodies do when we're exposed to severe heat is that we work very, very hard to keep that core temperature in place. It's a guiding principle of all the mechanisms physiologically that our body is working towards. It sacrifices other things to ensure that it can have that core temperature. So it increases metabolic rate, which increases, the heat will increase the metabolic rate, which increases core temperature, but very quickly we are working to sweat, we increase our cardiac output. And it's quite striking how well the body can compensate for this heat exposure day in and day out by shunting blood to the appropriate places to get rid of that heat. So at the top there is where it's compensated, but of course, when it's uncompensated, we can appreciate that a cascade of events can occur, especially if there is physiological vulnerability that can get us to a very bad place. And so once this compensation mechanism stops working, we can be decreasing our central venous pressure, which can increase our core body temperature even more. And then we start talking about some pathways that get quite serious in terms of cell anoxia, gastrointestinal permeability increases, cardiovascular collapse, inflammatory cascades, and the rest that can increase systemic inflammatory responses, and again, kind of feed this positive feedback loop of increased core temperature and ultimately organ failure and heat stroke. Next slide. So I won't go through each one of these points, but what I just wanted to maybe highlight is that there's the vulnerability, the physiological vulnerability of age, but in fact, this population of the elderly face many of the individual structural factors that put them at increased risk for not being able to compensate well to the impacts of heat. And then on the right here is, really understanding how the exposure to heat itself directly will impact our elderly patients. There's some studies that show that even, of course, we think and have concern about individuals who do not have an ability to cool themselves at home appropriately, and that being a significant risk factors. But even folks who do have cooling systems within their homes have been found to not be using them appropriately during heat waves. And so there's a major educational component here of ensuring that our elderly protect themselves during heat waves. Next slide. So again, just some overall statistics just to highlight just how much climate change is contributing to the increased risk of heat waves that are impacting our patients. This is a big study that many of you know about, that about 37% of all heat-related deaths could be attributed to global warming. Next slide. And just to make the point here that's been reinforced throughout this panel is that heat really impacts every organ system that we care about as health professionals. It has wide-ranging implications for our patients' health. Next slide. And just, this is a local slide here in the city of Cambridge. Whenever I see this, I kind of get jarred a bit every time I look at it. But here in the city, this is city data showing that historically we had about 10 days of over 90 degrees of heat a year, and then about a day of over 100. And then you can see, where we are, in kind of modern day now, how many of those over 90 days have increased and how much of the over 100 has increased. And then into the future, you could probably forget about that yellow and pink because those, thankfully, we're probably not headed to those climate models. But you could just see how much, we're concerned, in Cambridge and in the city of Boston of filling most of our summer with dangerous heat. Next slide. Okay, so now let's put a spotlight on the profile of the elderly. And I, of course, appreciated how vulnerable the elderly were, but when I was putting a few statistics together for these slides, I was kind of surprised, honestly, of just how disproportionately this population is impacted. So of the so this first study of GeoHealth showed that more than 80% of the 12,000 people in the U.S. who die of heat-related causes yearly are over 60. That major study that came out last year in Nature showing over 60,000 heat-related deaths in the 2022 European heat wave over the course of a number of months. 90% of those individuals were 65 or older. In the last 20 years, there's been a 54% increase in heat-related mortality for individuals who are 65 or older. Next slide. And so, it comes down to three major points, and they've been kind of highlighted in various presentations here already, but that these are really the major mechanisms. So why there is such a disproportionate impact on the elderly? Number one is because of body regulation and compensation. So all those cascades that we were talking about at the beginning, the elderly have a more challenging time compensating to maintain that core temperature. They have a lower capacity for, those were supposed to be arrows there, but lower capacity for cardiovascular response and capacity to quickly shunt to the skin and have a sweat response to dissipate the heat. Number two, they have accumulated more comorbidities, particularly in cardiovascular, but also in issues of mobility and being able to take care of themselves during a heat wave, cognitive function as well. And then, as was just so nicely presented previous to me, the importance of medications. And of course, there's an increased medication burden in our elderly population. So those are the three major mechanisms of why the numbers are so high for the elderly. I also just wanted to make the highlight that, I am really struck, and I think we need to put a spotlight on the impacts of climate changes, impacts on heat at nighttime. Of course, we're seeing these, extraordinary numbers during heat waves during the day. We're looking at Phoenix over the summer and seeing it climb to the 120s, 130s. But sometimes, what we should be even more concerned about, or at least as concerned about, is that the nighttime lows are quite high. And so for all populations, but especially for the elderly population, it's critical that our body is able to have that time at night to recover from heat waves, and having a high temperature at nighttime interferes with the body's capacity to reset with sleep and cognition. So while sometimes we think about kind of the dramatic heat stroke cases of the elderly during a heat wave, we should also be thinking about the kind of chronic and more insidious impacts of the impacts of heat, chronic heat. And this is where I think the nighttime heat plays a major role in issues of chronic, impacts on cognition and mood and more. And then I'll highlight here again the social vulnerability of the elderly population. 24% of people over 65 years old are socially isolated. There are major implications on economic vulnerability and the impacts of structural racism on large parts of the elderly population. Next slide. Here again, I just want to put a spotlight on the equity implications of heat and heat on the elderly. As we all know, issues of heat islands where poor communities of color are disproportionately made of concrete and asphalt, where heat can be significantly 10, 15, 20 degrees Fahrenheit hotter than neighboring communities that have more green space and tree canopies. Plays major roles in the outcomes of our patients. Next slide. And this study that many of us, again, are familiar with is showing the impacts of historical racism and redlining. This study, Jeremy Hoffman showed that redline communities are 2.6 degrees Celsius hotter than non-redline communities. So our elderly are disproportionately impacted by the impacts of heat, and the impacts of structural racism are in full display for this community, this population as well. Next slide. So there's a lot we can do. Of course, this is, we need to think about what we can do at the individual level with our counseling and provision of care. But of course, we need to be focusing on the structural interventions. This is a great study that came out last year in the Lancet showing, how much increasing tree canopy to 30% can improve some of these mechanisms we're concerned about. Can be decreasing the temperature of urban environments by 1.3 degrees Celsius if we get that 30% tree canopy, and could be decreasing and preventing premature deaths by 1/3. Some really, really significant numbers. Next slide. And so recommendations here, I think for our elderly, we need to just double down on what we know is true for all of our populations, but with maybe particular consideration for this population. The counseling preparation is really important. We need to be having proactive, preemptive outreach as heat waves are coming upon our patient populations, especially the importance of hydration. Again, as a primary care doctor, I have to be honest that, prior to my work in climate change, I don't know if I was really asking the right screening questions of whether my patients were safe at home during a heat wave and what kind of cooling systems they had at home. This is obviously very important, and not only that they have them, but again, that they know when and how to use them. We often will just be looking at the weather reports and be thinking about what if we react to the heat temperatures based on our sense of what is too hot. But it's important to just recognize that even more subtler increases in heat can impact the elderly. And this is especially important, of course, with humidity. And so we've got to ensure that our calculation of wet bulb temperature and humidity is a central part of our analysis of when it's too hot for our patients. I think we have some really hard and important questions about medication adjustments. One of the studies that's been referenced a few times during the last hour, the Leighton paper and PLOS, that was showing significant, increased risk of hospitalization during heat waves for patients on ARBs and ACE inhibitors and loop diuretics, antipsychotics, beta blockers, anticholinergics, increasing hospitalization somewhere between 20 to 33% based on which medication. But I think we've got to do a lot more work to be able to study and translate those studies into how we counsel patients about how they change their diuretic medications. And frankly, I think that's a real challenge we have in front of us that we need to take on. And then, of course, the basics of social support and identifying who is going to help people, the elderly, when the heat waves descend upon us. Touched upon a few of these, but structural solutions and addressing inequities. We got to keep, I think sometimes we lose the big picture here that the best way to help the elderly be able to compensate during heat waves is to have them be healthy in the first place. And so making sure that people have excellent health care and are healthy throughout their life, we shouldn't be losing track of that. Increasing green spaces, tree canopies, and of course, access to care. Point was made, many times, but previously about the importance of education in our students. But we've been trying to do some work here at the med school of providing, really some screening tools and educational tools in our precepting sessions to respond to educating our students on how to counsel patients. So that's all I have. Thank you so much. And I think I'm passing it to Caleb.
Minutes of this session. I'm an ER doc. I talk through chaos all the time, so do what you need to do. We're going to spend the last few minutes here trying to synthesize all of this into okay, what do I do? I work in a clinic. I work in an ER. I work in a private office. How do I take all of this information about heat and what it means for medication management, what it means for pediatric patients, pregnant people, the elderly? How do we take all of this, internalize it, and then put it into action in our workplaces? So what I'm going to describe is a little bit of the work of the Climate Resilience for Frontline Clinics program, which has been done in collaboration with AmeriCares. I'm from the Harvard Sea Change side of it. Elena, say hi in the back, is from the AmeriCares side of it. And there are several other people in this room who have worked on this project in various capacities. So the basic idea behind this is that while I work in an ER and I treat heat stroke and I treat patients with mental health emergencies during heat waves, that is not the right place to solve the root causes of this problem. And we need to be looking at a social determinants of health and an ecological determinants of health, a climate determinants of health model to get to the root cause issues that actually keep people out of the emergency department and happy and healthy at home with their families. So I want to sit for a minute with this equation up here. I realize it's a little hard to see, but this is the risk equation that we would use in a field like emergency management or disaster medicine, where we're trying to figure out who's at risk or what does risk look like in a city or a clinic. And it's a function of the hazards we're facing, things like a heat wave that's going to happen, but also a function of whether we're exposed to those, whether we have the capacity to deal with their impacts while avoiding harms. And then if those do occur, who are we talking to? Who can we lean on to stay safe? And so when it comes to something like heat, I want to highlight a couple of different programs we've worked on. If we look a little bit upstream, heat happens in the community. People are not usually in the hospital when they start down this pathway toward heat stroke or toward a psychiatric emergency. And so we need to be looking at what can happen to support people in the communities. Phil, somewhere up there from Johnson & Johnson, thank you for supporting one of these programs, which is focused. There'll be more information coming out this summer on developing resources for frontline clinics to prioritize relationships with community-based organizations to do things like get air conditioners into the hands of people who are at high risk, or figure out who they need to check on from their patient panel and who might be able to help them do that. So these are attempts to reach root causes, and those can be complicated, but I think there's a lot of opportunity there. A second piece I want to talk about is stuff we can do in clinics today with something called the Climate Resilience for Frontline Clinics Toolkit. This came out of research that was led by Ari Bernstein at Harvard Sea Change when he was there and the team at AmeriCares that basically boiled down to asking people in frontline clinics that are serving the highest risk communities around the United States, what are you seeing? What are you ready for? What do you need? What are your concerns? And some of the things that came up were gaps in resilience readiness in a lot of clinics, which are not in an acute care hospital, do not necessarily have the infrastructure or financing that comes with that. And in many cases are still seeing impacts from climate-related hazards, including heat, and it's costing them. They're having to plan for this, they're having to budget for equipment and training. When they were asked, what do you want? A lot of this came down to well-organized information-based resources that could be applied in low-resource settings. And the result of that was this toolkit. It's broken down by several different hazards. We're going to focus today on heat. And the idea here is that it's providing guidance for several different groups of people, including the administrators who run the clinics, who have to figure out who's going to make it to work today. Do we have water available in our waiting room if patients come in hot and thirsty? There's also information for nurses and doctors and social workers and pharmacists on some of the literature that has been mentioned today, distilling that down into a 1 to 2 pager where you can get the answers you need pretty quickly. And finally, information for patients. And we'll be running a session at 5 today in which anyone who's interested can come and give us feedback on some of those patient-facing resources. So let's take a quick look inside. This is from the flooding toolkit, and this is one of the checklists that an administrator at a clinic might access during a flood. We've been doing key informant interviews with individuals at clinics that implemented these toolkits, and we have, among other things, gotten pretty positive feedback on these checklists that take a pretty complicated set of emergency management questions and then get them down to a pretty quick, actionable list for something like a free clinic that may have limited staff. On the heat side, there are a lot of resources to go through. We're not going to go through all of this right this second, but I will show you the patient-facing piece of this, which we'll be reviewing at 5 o'clock for those who are interested. And it's just 3 pages here. There's some information about how do I figure out how hot it's going to be and what this might mean in terms of how dangerous it is. How do I stay hydrated? When we have done feedback sessions and focus groups with people using these resources, this "what color is your urine" chart is incredibly popular. People love this because a lot of people they are working with may or may not understand how kidneys work or what urine color implies about hydration. And so this is a really simple visual tool that can be used in the clinic for counseling patients who are at risk of heat-related illness. And then finally, we need to recognize when things are getting dangerous. And that's not just in ourselves, but it's in people around us. On the subject of the elderly, social connectivity is hugely important. Checking on the grandmother who lives alone across the hall in your apartment building could be life-saving. And so having a little bit of awareness, not just in patients, but in caregivers, in family members, in community members, on how to recognize when things are getting to the point where they do need to come to the emergency department, that's also really important. So there is a lot of work to do in this space. I think we have a pretty good first version of this out there. It's been downloaded almost 13,000 times around the world. But we want to continue to listen to all of you on how to make this better and better meet the needs of the people we're trying to reach. And so if you're interested at 5 o'clock, I would love to hear your perspectives on some of these patient-facing resources. So I will pause there, and I think we can take questions.
We have time for one question, I think. And also, I was really glad that Gaurab brought up about heat pumps and cooling. And right now, with the Inflation Reduction Act, low-income residents for the first time can access funds and don't have to wait for a tax rebate. And these are going on individually in states. And my organization, Alliance of Nurses for Healthy Environments, we're doing a blog post that'll be coming out in like a week or 2 on how to access those resources in the states so that if you have elderly patients, they could get a new, very energy efficient heat pump for heating and cooling. So just putting that out there.
Hello, okay. This question is from the Zoom chat, and it's for Dr. Berenji. In the states where there is a standard for outdoor work, how successful have OSHA or other regulators been in ensuring compliance and preventing HRS?
The answer is easy. They have not been really good at the compliance angle, unfortunately, because there's a lack of staffing. I mean, a lot of these regional OSHA offices are extremely short-staffed, and being able to get people out to these locations has been very challenging, and it continues to be challenging because of limited resources to actually hire the appropriate staffing to do these types of assessments. So hopefully, with raising awareness in this type of forum, we can encourage our state legislators and hopefully even our federal legislators to really think about how we can get more staffing for these OSHA offices, both federal as well as state OSHA. Not every state has a state OSHA office. So that's another angle that we have to take into consideration.
Thank you.
One.
Oh, we can't say no to Rob.
Yeah, okay, one quick question, one more.
Is this on? I don't know. I just wanted to make a comment and draw the connection between where we've been today. Mustafa started with a little story about his grandma and the community he grew up in and everybody checking on everyone else. And of the many stories that have linked today with what you've talked about, we've talked about medication and what we can do in that regard and how we approach people during extreme heat and what we can do clinically. But I would suggest because the most extreme risk is during heat waves, they come on fast. It's the delta in above the normal heat in one's community, and that we're not going to be able to dramatically change this by managing our medication strategies. It's just too quick. And old people die in their homes, isolated and alone. So I loved your responding at the end with that we need to have embedded community kinds of responses, checking on people. And I want to connect that with what Bob Fetter has brought up about the community wellness legislation, which is really basically codifying and giving money through legislation to create the communities that Mustafa told us about this morning.
Great, thank you. And thank you to all of our speakers.